Thank you for coming to our meeting. Usually I give a few words before I give you the presentation. So he has an impressive bio. He mentioned he is the Division Director for the Georgia Department of Human Services, Division of Aging Services, part of the Federal Older Americans Act. He is an applied gerontologist with over 16 years of experience working in the field of aging services. He brings vision and direction to the Division of Aging Services and the Aging Services Network through the creation of an innovative and effective service delivery system which serves older adults and persons with disabilities and allows access to the services they need in order to remain in their homes and their communities for as long as they choose. So today, specifically, Dr. Bullock will discuss how he has been performing and the services that they have been delivering under his supervision. So analyzing impact, appropriateness, cost, and easy of use to determine what technologies really dramatically impact our older adults to age in place. So I think I'm going to stop here and I will give you the command. So welcome and thank you again.
Thank you. About 2 weeks ago, Brian asked me to think about how we could make the session or the discussion or the talk a little more interactive. And after hearing who some of the folks are around the table, I think that was really a very good idea because we really are at the Division of Aging Services. And how many of you are aware of what it is we do there? Some of you are, some of you aren't. And some of you may have heard me speak before, but I generally say that the Americans Act was created in 1965, or signed into law in 1965, and the structure that was created then really hasn't changed very much in the last 40 years or so. The way we're structured, the way we deliver services, even to some extent the type of services we deliver hasn't changed, and the types of services we provide, when they were created to address the needs of the outliers. Those individuals who happen to live to exceptional old age of the late 60s and 70s and 80s. Well, now we are 40, almost 50 years later, and the outliers are now almost a mean, and our service delivery system is still the same as it was in the 1970s and 1980s, with some small tweaks in the early 2000s with the National Family Caregiver Support Act. But the funny thing about that program, while it was supposed to be innovative, is it just took the service array that we were provided in 1999 and called it the National Family Caregiver Support Act. Same type of services we were delivering to everybody else, we just targeted towards caregivers now. It gave us a little flexibility in age in which we could address needs. We can't continue to do things that way. The types of services we currently deliver, they're somewhat costly. They demand people provide the services, and right now with the amount of funding we receive, and it doesn't look like we're going to get any more funding, at least not based on the projected demographic growth in the older adult population. We need to start looking at more creative ways to address the needs of an aging population, start looking at technology, because right now technology really hasn't been at the forefront or any thought in how we address the needs of an aging population. Outside of the private pay market where people have the resources to seek out technology to assist them remaining in their home by and large. So I thought what I would do and have a really frank discussion on technology and aging in the state of Georgia, maybe a little bit kind of nationally what's going on, and discuss, I have some issues and some ideas that we're trying to address within the state office on how we start infusing technology and how we address aging concerns. But there are many barriers. Those of you who work in technology, yes?
Yes, can you just give us an overview of what technology means?
Well, let me give you a little bit of background on myself first. You mentioned some stuff. I got my undergrad degree in psychology with a minor in computer studies and some other things. My PhD and my master's was in gerontology with an emphasis in research methods and stats, and then my PhD was in public policy and aging. My dissertation was on technology and aging, how older adults interact with the emerging internet at the time, It was quite a few years ago when we couldn't find quite as much information as you are now. I'm also a certified aging in place specialist, and was formerly, before I left Louisiana, providing primary care for my grandmother in my home. Technology for me is anything, and it doesn't have to have circuits and memory or anything else in it to be considered technology, but any tool that a person can use to allow them to remain in their home. In the context of aging services, now you can take a much broader view of what technology is. But that is how I view technology. I know a lot of times when folks who work in the field of aging hear technology, they automatically think about computers and very complicated interfaces and technology and user manuals that are about 3 inches thick, and people get scared of it. But technology can be a fork with a cushioned handle that makes it easier to grip. It doesn't have to be fancy. It doesn't have to be complicated. When my great aunt was in a nursing home, we used a piece of high technology to help her drink. It was called the sippy cup, because she wasn't able to drink out of a regular cup, and the straws, the little flexy things on them, just didn't work for her when she was in a nursing home. It took all of about 3 seconds whenever I was in there to realize that, yes, she needed something, and I had 2 kids, and the sippy cup worked great for them to keep them from spilling, and it worked well for her. So that's technology. That's kind of how I view it. But throughout the way aging services are delivered in Georgia and really across the country, they don't look at technology as really a viable option. They look at those traditional services that we've always provided. And what are those? That's your home delivered meals. Everybody's heard about those things. It's your personal support attendants, your personal care attendants who come into the home and help you with the bathing and the toileting and the other ADLs and to a lesser extent your IADLs that you may have issues with. It is the homemaker services. Somebody comes to your home, they clean it up and to straighten things up so you don't trip or fall over, the rugs that got messed up. It is, to some extent, the medical side of it, the home health. We may provide nurses in the home on a limited extent to help people, but that's really it. We do a little bit of medication management through the services we provide. Yes?
I know that nationally, the Older Americans Act provided for, I believe, the assistive, or the ATD.
Yep, sure.
What do you call them?
Huh? Assistive devices.
Right.
Yeah.
Well, okay, but it's the centers that you have operating around the state.
Oh, area agencies on aging.
Right.
Yeah.
Okay, and there's also some resource centers as a part of that.
Yeah, aging and disability. Yep, aging and disability resource centers.
There's some more funding coming down that will support those, and to what extent with technology?
Well, and this is, we're battling technology in the state of Georgia quite a bit. I never thought it would be quite so difficult as it is here. But we're on the cusp of either falling behind or getting ahead, and I'm not quite sure where we're at yet on that. With the technology that we have, and the ADRCs are really, and that's one of those things which I had to give a talk on the future of aging services, and I mentioned the outliers, and that is, that about 5% of the population, any population in the U.S., requires a nursing level of care and resides in a nursing home right now. It appears as if in Georgia and Louisiana and the other states that I'm very familiar with, another 5% of the population requires the type of services we provide, those in-home supportive services. The other 90% of the population over the age of 60 lives relatively well on their own without any assistance from the state or federal agencies outside of Medicare and Social Security, the stuff that everybody gets. But that 90% of people, and even the 5%, we're going to struggle providing services to those 5% of folks. Within the 90% of people, we know there are people who struggle, but they don't know what services are out there to allow them to remain at home in a manner which promotes dignity and independence and all these other things that we promote. And I think the ADRC, the Aging Disability Resource Centers, is one of those vehicles in which we can start touching that 90% of the population. And for Georgia, that 90% of the population right now, we have 900,000 adults over the age of 60. In 2015, that number is going to get up to about 1.2, 1.3 million, the fastest growing population. Through the ADRC right now, we're able to serve more adults just with access to information and referrals than than we are with any other program by far, because it's I'm going to use the term cheap, and it's all relative. It's cheap, it's efficient, it's somewhat easy to access right now, but we're limited by the types of technology that we use. And ADRCs, they were a great concept because the systems that we have in place right now are just difficult to navigate, they're difficult to access. If you've ever tried to figure out how to get somebody on a waiver or into well, nursing homes are relatively easy, but get somebody on a waiver or navigate Medicare Part D, or what is A and what is B and what do I need? Oh, it's messy. I had to help my grandmother when she was living with me with Part D when it first came out, and I taught for about 6 years. I was an academic director of the gerontology program at the University of Louisiana, and I studied Medicare Part D as it was being developed. I was following the policy, and I knew everything there was to know about this program. And when it came time for my grandmother to sign up for it, I was lost. I mean, this thing was just it was not easy to work. So the ADRCs, they were created to serve that purpose, also to kind of smooth the path that people take whenever all of a sudden they're put in a position where I've never, for the 60 years I've been alive, needed somebody to help me, and all of a sudden all these new things I have to worry about, and I don't know how to work them. So that's what the ADRC is really good at. But the problem is it's scalability. Just with any other new programs, and we're talking about technology, it's one of those struggles that we have is how do you come to scale on technology throughout the state. So I said we were at the cusp of technology, and we're either going to get ahead of it or we're going to fall behind it. And that's where we are with the ADRC right now. Looking at the demographic growth and how we're structured. Right now we're really people dependent. The ADRC is people dependent. We haven't quite, and I don't know, we're not working on it, but we haven't quite figured out how to make that virtual front door, that access through technology, whatever type, whether it's phone systems or internet or anything else. How do we develop a system that captures the power of the individual interfacing with a person? And older people, so far, at least the older adults, tend to prefer the human interaction. But now, as we're looking at the younger population, we're seeing a lot of change there, with the emphasis on consumer direction or self-direction. But how do we develop that virtual infrastructure that would allow us to touch? Right now, it's about 75,000 people a year through ADRCs. That's through the phone and picking up 1-800-866-55-AGING. There's only so much we can do, and it's come to scale to serve 900,000 people, or even 500,000 people. Let's be conservative. With manned telephones throughout the state of Georgia, and that's how we're structured. We have 12 regions and 12 offices that function as local ADRCs or regional ADRCs, and people call, and they get put into contact with a local individual. Well, that's great for the people who need that. But how do we develop that virtual infrastructure? And we're struggling with it right now. Because there's no system right now that brings together all these various entities that people have to navigate and work with whenever they need supportive services in a home. People are really good at thinking, and much better than your search engines a lot of time whenever you're trying to find support services. So it's a lot easier to talk to somebody who knows the resources, knows what's available in a particular area, and can talk to an individual and say, well, what it sounds like you need is this. And you know, and it's a lot of experience that goes into making those decisions. And how do you transfer that human knowledge into a computer system, a database that people can navigate on their own? And that's what we're looking at right now with ADRCs is a virtual front door, relieving right now some of the demand on the human interaction, saving the human interaction for the high need, the difficult individuals that can't navigate a virtual front door, and making that virtual front door available to a much broader population, allowing people to really self-direct. If they see a program that they qualify for, allow them to take the initiative and fill out the forms if they're needed, or family members, and then automate as much as possible, which is where we need to be. We probably ought to be there now, but we're not there yet.
Do you know if any other states have developed the infrastructure? Data? I mean, every state is different in terms of the
every state is different. Yeah, most states have an ADRC right now, and even by the national criteria of ADRCs. We have a virtual ADRC. Yeah. What that means is you can pick up a phone and talk to somebody. You don't have to go to a front door, literally walk through a front door and access the information. So most states have that virtual, but they don't have that true, you know, what you might consider in the field of aging and even in disabilities. You know, we've been talking about the single point of entry concept, or a single entry point, and it means different things to different people. But we don't have anything like that's electronic that people can access. And a lot of times as we get older, at least what we see in aging services is family members are a lot of times involved in making these decisions and are the ones navigating these systems on behalf of their parents or grandparents, as was the case with my family. Yes?
Yes, you mentioned before that, well, that we need to be creative, like in order to help our older adults remain at their home. And you said that we are more kind of like service-focused than product-focused, if I understood correctly. So I have like two questions. Like first, why is that mentality happening? What are the barriers? And second, have you done any pilot studies to justify that mentality?
There have been pilot studies done with technology and aging. State units on aging. State units on aging in general, and I serve on the board of the National Association of State Units. It used to be State Units on Aging, now it's National Association of States United for Aging and Disability. Yeah, broadening their focus. We just say it's NASA with a silent D. But states rarely have the capability to conduct pilot studies. Now what we're doing in Georgia, and again, I don't know of any other state that's really putting a focus and as part of the, we're developing our next 4-year plan for the state, and technology is a big part of that. And wherever we could, in our assurances to the feds, we wrote in technology as a resource to meet the needs of an aging population. So in dietary, for example, we do the meals programs, and I instructed our staff, every place that it was even possible to include technology in the C1 and C2 meals, I want to see technology in there. And the in-home supportive services, technology everywhere through that. So one of those barriers that states have battled is while the Older Americans Act is great, I mean, when it was designed in the 1960s, I mean, they really did a really good job, probably one of the best pieces of legislation that was enacted, although it wasn't enacted as an entitlement. So it means the funding that was created in 1965 has remained, if you adjust it for inflation, steady since then. It has not seen any growth. Now, adjusted for inflation, the curve is a very slight upward increase over the last 40 years or so, but not a lot. As we started to see technology and use technology to help keep people in a home, the Older Americans Act, all the funds have historically been expended in these few categories, and you battle what are very popular programs among state legislatures, among constituent groups and everything else. So you battle what was eating up 100% of your funding with how do you start carving out some of that funding to try these new things, to try how does technology work, and as we're framing it within our offices, if we don't start carving some of that stuff out now, instead of having, we have a waiting list of about 26,000 people, for various services, and it's a duplicated count. But instead of having your waiting list of 26,000, you're going to have 30,000 and 40,000, and once you get up to 40,000, it's really make a difference. So the approach we're taking is, well, we got 26,000. Does 26,500 make that big of a difference if we start carving out some money for technology and aging? So Georgia right now, really, as we move forward, now again, I've only been here for less than a year now, and it takes some time to get these things moving. But we would like to and I'm not going to call it pilot because we're not going to do any research along with it because we know the research has already been done. We know these programs and we know this, not programs, but technology is effective for people. If you look at individuals in states where they have technology included in waiver programs, for example, you see technology being very effective at helping disabled adults remain at home. So we know the stuff's there. We're not going to do the research behind it, but we're going to start carving out funding and start working with our providers to say, okay, how do you as a provider start discussing this with a client, the technology side of it? How do you start looking at technology as an option for somebody?
I think I made my question towards that, not so much about the research on it, if it's effective, but pilot seems like how we can implement it, how it can work, so we can have something tangible to say we need this. Okay.
Yes. But this is a struggle, and that's why I thought this would be a really good group to kind of start this discussion with. Is we have some people who are providers now, and I recognize some of the names. I think some of our AAAs and subcontractors use some of that. It's really a big deal right now. We have one region in northwest Georgia. They have 5 clients receiving in-home monitoring. You know, the cameras and everything else. That is huge in aging. I'm being sarcastic because it's not really that big, but in aging and using older American Act dollars and other things, that is a really big deal because they've never really thought about doing this before. So it's really a culture change and a culture shift in aging to start looking at technology, and we've always been on the provider side or on the service side, people focused on how we deliver something. So it's always a person and these high cost things and things we really don't have any control over when minimum wage increases, and so it's a tough sell among a group of people who have been in the field of aging when the microwave was high technology to heat up a meal. To start getting them to start thinking about, what is the future of aging, and the technology we have out there now is really incredible. And I'm talking about incredible, not only just the medication management systems and everything else, but it's just the low-tech stuff, the plates with an edge on it that you can shoot your fork against and stab your chicken nugget and eat it. Yes?
Jay, can I just add that I work with the area agency on one of the 12 area agencies on aging, and also in response to the ADRC, we have a database that we have of resources, and in that database, one of the things we have is Assistive Technology devices. And we developed that. The database has been around for 15 years, has 24,000 services, private, for-profit, governmental services, and we've really tried to establish a partnership with the providers to make sure we're gathering the information. And one of the things I've realized by attending this session in the last couple times is that we really need to have a focus this next year on that whole category that we have called advanced technology devices, because we do have daily living aids, we do have the emergency response providers listed in the system. But I don't have the expertise to take it to that next level that you're saying we really as a state needs to take. So I'm hoping that through participation, maybe even of this group, because I'm realizing the experts are here at this table, that we may be able to really take that category that we have in the database, and there are about 700 adult protective service users work it, some hospital systems use it, some agencies use it, and really expand that information because it is very detailed oriented. So just
is there a URL? Is it a secured access kind of database to look at what you have there? Or
it is the professional tool that the Aging Services Network uses at the
but
case
it's not
management.
open to other people.
Well, what we do is we roll some of that information over to a statewide resource database that's Georgia Georgia Services for Seniors.org. And so that's something that maybe we can look at, and that interfacing part that you're talking about that is so important, to get to.
And that's what we're struggling with. We're struggling with two things. One of them is a structure, a statewide structure that hasn't ever systematically thought about how to use technology. But the other one is, and this is where you all work. You see this in the labs all the time or with your clients. Is a lot of hesitation and there's some fear around technology. And when you break it down, older adults they're really not technology averse. It's just I don't know if stigma is the right word for it, but there is something about when you think about technology, and I mean it's that darn VCR and the light keeps blinking, and I mean, and that's still stuck with people for years and years and years, and it's gotten the user interfaces have gotten so much easier now than they used to be. But that stigma associated with technology and just in general is still there. So we're battling that on both ends. We're seeing, I mean, the younger population, the disabled population, are much more open to really being heavy users of technology to assist them in their lives. And I think in the next 5 to 10 years, the population we serve will be. But it's it's the folks that we're serving currently. How do we start getting that? Because if we don't get it infused through how we start talking about aging and supportive services, now we're going to be in a whole lot more trouble in 5 to 10 years when the population has doubled and service demand has doubled and funding has remained static, and then we're still providing the same 15 core services that we've always provided.
It certainly sounds like by the time you get it in place, the populations that will accept it will have caught up with you.
But people are also living much longer. So the population we're serving now, who's in their 70s, they're likely to live for another 20 years now.
But I mean, the big bubble of baby boomers is going to be into that.
So it sounds like one of the big gaps is like, you have all of the individuals that you're serving and all this wonderful expertise around the table, but the gap is funding for pilot studies that could really bring together.
Well, and not just that, I think I'm kind of shocked to hear your information because the care managers that I have interacted with have no interest in providing. I'm sorry, I mean, that's just my experience. They're like, well, it's not on the list, sorry, I can't provide it to my consumer. And like you're talking, I think it's also a terminology thing. We're talking, his vision of technology. When you use the term technology, it's like, oh, no, sorry, I don't want one of those button pusher things. When it could be as simple as a little, handle by the bath, and that's the thing that even educating, can we do a statewide education to care managers about what all is out there that they're missing? Because they're the ones that are connecting people into it.
Well, you got two things.
We did a little demonstration project back years ago with your office and Alan Goldman, and there was a small amount of money. It was like $5,000, and we worked with one of our Centers for Independent Living in Augusta, and what we did is we just built a small display with, simple aids for daily living, and we rotated around to different AAs, AAAs. All of a sudden, the Independent Living Center got 200 phone calls from older people going to the AAA, said, where can we get this? Well, there's no funding for it. So Walton Options Independent Living.
And I want to address the funding thing, because I mean, funding is an issue. Just like with anything else, I think the funding's there to start doing this. And I'll give you an example. And you've heard me talk. Some of you have heard me talk about this. Our most expensive client, who's receiving services through the Older Americans Act, which is a non-means tested program, is receiving $22,000 a year worth of services. Now those services are primarily for 5 days a week adult daycare. Not adult day health care, but adult daycare. Now, those of you who provide the home monitoring systems understand that, that piece of technology can be a replacement for adult daycare, assuming the individual is safe to stay at home and everything else. So the home monitoring for that person might cost $5,000 over the course of a year, the upper end of it. So you just freed up, $15,000, $17,000 for other services. So I think the money's there, but we've got to start working towards, start looking at more efficient, more effective ways to provide the services. So we have homemakers come in and do X, Y, and Z. Well, I mean, do we need, because that's, I don't know what minimum wage is now, $7, $8 an hour. That's $8 an hour, over the course of 4 years, because people stay on our services for an average of 4 or 5 years. If we start cost calculating that out, so yeah, it's only costing us an average of $1,700 a year for all of our services for the average person, average client. But
I have a question back
yes.
here. On the monitoring, we had someone who's getting home monitoring. She had heart failure, did very well. The monitoring was done by the home health agency, and as soon as she got better, the funding ended because she was no longer homebound and the service was ended. So how do you provide continuity of services, and what role are the third-party players in Medicare paying in continuing home monitoring, and who will monitor it? Because that seems to be one of the issues.
Well, one of the big things that I read about recently is with CMS is they're just now recognizing electronic services as a reimbursable service. So this is actually a really big deal, and again, in this type of thing, because this environment, the home monitoring services and everything else, before you had to get really creative in how you requested reimbursement for those types of services. Where now, Sibelius has publicly stated this is something that will be supposedly included in as a reimbursable service now through CMS. So,
but who will do it? Because you're not going to have a home care agency in there when they have other cases. Is it going to be the doctor's office?
Well, we have some people here who provide the service, and this is
the vision is that eventually you would have 3 8-hour shifts of a CNA watching a bank of monitors and supervising these people. Down the road. It's right now, though, the family resources is private pay and getting those resources together. And even some of the technology, Rick and I have had this conversation with the PERS, the Personal Emergency Response System. They're so fearful that if they press that button, their dog's going to put them in assisted living. They'll lay on the floor for 3 hours thinking, I'll get enough strength to get back up and do it myself.
Well, only 40% of the time are they even wearing it when they fall.
Right.
So
Yeah, and
Four out of 5 times when they fall wearing it, they don't push the button.
And then there's the whole issue of the use, the transition from clinical to home. We put medical stuff in the home, and people are not going to use it if it's medical, because that reminds them they're aging.
Yeah.
It's the whole thing of, if you do it non-medical, they'll use it. But if you make it medical, which everybody wants to do, and pull it out of clinical, they don't use it.
Yeah.
And so you've got this. When will the manufacturers get it?
I'll give you, and I was having a conversation with somebody now with, how do you know when somebody's having hearing and visual issues? And I told them, I said, if you walk into the house and they have a 50-inch screen and they have surround sound, and it was somebody who never really watched TV before, they're probably having hearing and vision issues. You call it assistive technology if you want. That's what it is. And again, I use my family as an example because they're fun to use as examples. My grandfather-in-law, who, he watches, what's the little cowboy guy, I forget what the guy's name is. That's what he watches on TV, black and white. You don't need a 50-inch screen to do that. But he's having hearing loss and he's having vision issues, so he's went with a bigger and bigger. And you can watch the progression year over year. But it's a piece of technology that has no stigma attached to it. There's actually a lot of, there's I got a 50-inch screen, So, and that's the problem with technology right now. You mentioned the PERS button. Right now we're in the middle of doing our public hearings across the state, and we're asking providers and seniors and clients to attend. And the emergency response buttons come up time and time again. But what also comes up is a number of seniors who, and this is my own interpretation of it, they're carrying a cell phone around because it's their personal response button. They don't make any calls on it, but they got that cell phone with them just in case, just like the button. But it's much more socially acceptable to carry a cell phone around than it is to have the little red button sitting on the middle of your chest, or the bracelet that looks obviously like a piece of medical equipment. And this is something that we have to, that we're, it's real now, but it's going to be even more real in the next 5 years and 10 years when the baby boomers, and some of y'all are in the room right now. You think about, it's something we're going to struggle with, and like I said, the 50-inch screens is one of these things that people accept. The cell phones instead of the emergency response buttons is something people accept because, well,
getting them to take that cell phone and ice it.
Yes.
In case of emergency, ICE, having that in there, that's an education.
Yeah.
And all the emergency response people, if they see a cell phone, the first thing they're going to do is look and see is there an ICE there. But no one knows that.
Yeah.
It's just getting the word out,
Okay, I'm going to follow up on what you said and go non-tech and high-tech, and just tell a very quick story that my doctor told me years ago, and he's an OBGYN who does high-risk pregnancies. And a woman was in labor and it wasn't proceeding, and she had all these machines around her and nothing was happening. And he just walked up to her, put his hand on the shoulder and said, honey, it's going to be all right. Boom, 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 labor started progressing. So how do we combine and it's one of my favorite stories. How do we combine the low-tech with high-tech? Now, I run a Newark, and there are others of us here from Newark, and what we have found, and we're in a more closed community because we have 2 independent living high-rises on our campus. And what I have found is the peer pressure and the peer support is getting people to get the personal emergency response systems. If one person has a successful experience, and again, it's not only for falls, it's if you're having chest pain, if there's an intruder in your house, and that's how we teach it. If you want to answer your phone, you can press the button. You don't have to rush to it and then fall. So we find we have a core group of women who are out there selling the system, getting members in, and also showing all the ways you can use it. And knock wood, we've been doing a lot of education. I've noticed our falls are going down, so I'm going to get the data soon. But I think we have to merge the two and look at, I think, the naturally occurring retirement communities, and working with the peer support are going to be a way that can really help this happen.
Yeah, and the peer support's been really successful in the DD communities on especially people, not just I guess not even just the DD, but just the disabilities community in general on helping people to understand and use and accept technology, whether it's a wheelchair and how to navigate around town in a wheelchair, or whether it's a motorized ones that go up and down stairs and all this other stuff. Peer support, call it peer pressure. You know, it works both ways. I'm a firm believer in peer pressure. I think you do some great things with peer pressure. Yeah, it's challenging.
I'm interested in the pilot program that you spoke about earlier with the video monitoring on there. What's one of the things that one of our focuses is in-home monitoring, but there was a lot of pushback on having the video cameras in there. So I'm curious as to what the results have been in the program that's going on in the Northwest.
I'll have to look into it. I don't know if it's the video camera monitoring or the motion monitoring, because you know there are multiple systems now.
Well, if it's ResCare, I believe it's video.
Yeah. You know, I don't know. I get videos sent to me all the time through YouTube and everything else, and I'm thinking the whole stigma attached to 24-hour monitoring and video and everything else is going to. I think we might view that a little bit differently in the next 10 to 15 years, judging by some of the things that people are putting online right now.
Well, I wonder if the fact that you know that you're being monitored changes your behavior. And is that necessarily a good thing for seniors, or would it be better if they were...
What is the seminal research that was done on, and it was an auto industry where simply the fact or the act of watching something without any introduction of any type of stimuli actually changes performance. It makes people a little more aware. But even ResCare, I don't know if it's family monitoring or if it's just strangers monitoring, or strangers meaning not family. Yeah.
James, you said something that I wanted to react to earlier, and that was this notion of a sippy cup as a technology. If you look at kind of our paradigm, you've mentioned expense and scalability as being a real problem. If you want to talk about safe drinking water, you can either build a bigger, deeper well, or you can give people a straw that filters out all of the harmful particles. And there's something that's attractive about the way that other countries and other societies are looking at technological solutions and coming up with very inexpensive solutions. I mean, some of the things that we'd like to do are just hugely expensive. You've got the input of cameras and technology. There's this issue about what people want you to see and not want you to see. And then every camera that you've put in, you've got to put some live person there monitoring it if that's the paradigm. So there's some real challenges there. In the VA system, which is one of the health systems that I work in, they're sort of how they get paid and how they get budgeted has allowed them to invest in technology and develop programs from a capitated framework that has allowed them to push into this technology. But if people are on disease management programs for diabetes, they'll tell us that if their blood sugar is 375, they'll put in 205 because they don't want to activate this response system because I'm in control, I know what I'm doing, I know I did something wrong, but I don't want people calling me up and chewing me out for this. So, I mean, there are some challenging things about paradigms that we've probably got to address before this just really takes off.
I agree. and it's something that, I mean, the cost is one of those things that we're struggling with right now. And again, I mentioned, I think we have the funding to do some of it. The very high tech stuff, I mean, somebody mentioned the robots. We're never going to fund robots in the home through our office. Unless they become affordable. I mean, just like, you know, I mean, we wouldn't have had, you know, these 10 years ago. We couldn't be able to afford the technology to do this now, and now you get them free with a 2-year plan. So, and part of it is scalability, and as more and more people start purchasing it, the costs come down, and economies and all that other kind of stuff. But, you know, I mean, you mentioned the medical devices, and I remember, was it over the summer, I think, the student at MIT who developed the negative suction on a wound. You know, it was a little expandable suction cup. Put it on there instead of the $1,500 piece of equipment to provide negative pressure on a wound to heal faster. $13. That's what it costs to produce. But if you go to a hospital here, it's how much does that piece of equipment cost to do? And well, they shipped it down to Haiti. I don't know if they've, you know, got the results that they expected to. But I mean, but that's stuff we need to look at. I mean, we have expensive technology, and that's appropriate for some people. But for a lot of people, we don't need the home monitoring. And that's what I said. I mean, the 5% of folks, that's the 5% who's receiving the home monitoring, the very costly services. But the 90% of folks, they don't need that level of intrusion. May be the wrong word for it, but they need the plate with the edges and the can opener they can operate, and the things that allow them to remain in their home independent. But it's a challenge to navigate that, and I mean navigate it from a state level perspective, trying to make sure that we're moving towards thinking about technology as an option.
One was brought up earlier that possibly we should look at other countries to see how, you know, creative they are in their practices to solve like problems with tiny or small interventions. So we have examples that we can discuss that you're aware of. Have you looked at them?
Well, the toilet, we had a guy who just came in, that's from Japan.
Japanese in their
Yeah.
obsession with chocolate.
And what was it?
Without being, you know, too graphic, it's the toilet that cleans you. And
Oh, the bidet.
Yeah.
Yeah.
The bidet. It's a little bit easier to operate than the bidet.
It's got a little remote control, moved a little, yeah.
A little spray, a little hot air.
Hey, you know, I mean, but and maybe it's changed now. Back whenever I actually did a lot of research, one of the best predictors of when somebody goes into a nursing home was whenever they become incontinent. And usually family's involved in it, and it's that point where family says, you know, this is a little too much. You know, I love you, Mom, I love you, Dad, but I don't want to have to wipe your butt. And that's, when you look at all, I mean, there's other factors, but if you look at, you know, kind of family structures, that's one of the best predictors of going into a nursing home, is whenever a person becomes incontinent. So, I mean, yeah, so we could spend how much for the bidet in a home, you know, to do the wiping and everything else, or, you know, $36,000 a year for a nursing home, you know.
It cuts down, they're using them in adult daycares to cut down on the use of the CNA being one-on-one with the person while they're bathing, and it cuts down on costs.
There's a lot of, and I mean, at the state level, we're looking at the Older Americans Act being one funding source, and there's some other things we can do, and I think consumer direction, self-direction is really the way to start tackling a lot of these problems, because people are different. You know, I mean, you don't want somebody from the state saying you can only have this, this, and this, and this. That's all we offer. That's all we do. And even though you know you really need this, I'm sorry, we can't pay for it. That's not a service that we approve. And through consumer direction, and the Older Americans Act, you know, there's not enough money in that program to really do consumer direction, what needs to be done. But the waiver program, and in our office we do the CCSP waiver. And as we're going around the state and listening to people and their issues, it sounds like consumer direction is the way that a lot of the individual problems can be solved, or individual issues. And what that means is, you know, real consumer direction means you as a person, or you and your family, know what it is you need to remain at home independent for as long as possible. You know, and you have a budget, and you budget those funds, and you purchase those items, whether it's a person or whether it's the technology. You purchase that to help you, and the decision's made at the individual level. We can't do that now. That requires CMS changes, and our waiver rewrite happens next year. But but we're doing the public hearings right now to get a feel for what are the things you need. And technology, believe it or not, has come up more and more as things that we need access to, among whether they're current clients or whether they're just older adults or whether they're providers. I mean, I'm not seeing the demographic breakdown of who's making these comments, but in more and more public hearings, technology has come up, which is for me really reassuring, because I'm a big believer in using technology whenever it's available. So.
Can you tell me how to find out about where those are held, the public hearings?
Yes, I think we they should be on the Division of Aging Services website. We're almost done with them. We're actually going to have one more in Gainesville, because they forgot to invite consumers. So we got a really good idea of what providers wanted, but not an idea of what the actual clients wanted, or potential clients wanted, and the types of services we administer. So we're going to have another one there. But yeah, it's on our website. And
when there's the charrette meetings, have you been having? It's not the charrette meetings.
No.
Will that be this year, the one in Gainesville this year, before the end of the year?
Yes, we're going to have it before the end of the year. It actually happened already, and they didn't invite any consumers, so we're going to have another one there with consumers, because that's really what I mean, providers are great, and if you want to give me something cheap, that's even better, but I'm more interested in what the individual wants, the person who's the end recipient. But I like what you were saying about what about other countries? I mean, because we do, we do tend to look at things more, especially in the aging side, on the really with a medical lens in the home, and people. There's, as you mentioned, I mean, that's a medical device, and all of a sudden, if something happens, and my doctor's going to call me or something else, but I mean, ramps, for example, that's a very piece of low technology that assists people. With the aging in place specialist, I mean, there's lots of things we can do in the home that helps people. That does, I mean, it's call it universal design or whatever you want. That are things that are relatively inexpensive but can help people stay at home independently.
Well, if we had a better system of looking at gently used items that a person no longer needs and family no longer needs, then that can go back into, and how do we support that? Some of the things that we're looking at.
Yeah, and that's bouncing around our office as well. I mean, I mentioned the person with the $22,000 a year and adult daycare costs. Is there something we can buy? Right. It might cost $5,000 in 1 year, but we'll get multiple years use out of it, and maybe it really is durable. And I mean, I'm not gonna call it a lease, but I mean, when it's done, since the state paid for it, it comes back and we redistribute that piece of X, whatever it is.
We are working with Medicaid to look at some of those things, because in our state, the ownership resides with Medicaid. It doesn't transfer to the person, so there's no need for any kind of legislative change to really begin to look at that and make better use of some of the things we're already paying for.
I think that there was some interest in possibly bringing that up as a co-age issue, which is the advocacy arm of things.
Great.
And if anybody's interested, that the Council on Aging, that would definitely be a vehicle to pull that through.
Definitely. And I know also that Chris Brand at FODAC is very interested, since there are lots of people from Georgia Tech here, and if there were a student design project where they could go there and really look at how he's laid out the space in the facility, and industrial designing to make better, flow and those kinds of things. If anybody is interested in that, then that's something that we could talk about.
Well, students, you guys are reading a lot of research and looking at a lot of articles and stuff. What is the big stuff going on right now on the research side of things? I remember when I was a grad student, I was sitting in the subway station at Boston, and I remember reading in Switzerland or Sweden or somewhere out there with an S, they developed a floor. And this floor, somebody would have a fall, and this was back in the 90s. And somebody would have a fall, and this floor would take their temperature, and it'd take their blood pressure, and I'm thinking, I'm sitting here with my little book, social policy and aging, and I got all these little notes on there, thinking, wow, this is cool. You know what this is going to mean in the next 10 years? And I've yet to see it. But I mean, I'm sure there's something going on right now that's got to be, you know, exciting for you that you're reading about.
Well, they have specific scenarios that they're designing for, like Stephen, Lilia, Hani, they all have like different needs. Those needs were identified from previous study that we have done with Brian, and also there are some scenarios coming from John Stanford at the NORC. You're welcome to talk about what you have been finding out.
Well, my scenario is dealing with arthritis, so I'm working with things in older adults with houseplants and how they need to take care of them. So I've been doing a lot of research with the limitations that they have.
So currently, Stephen is looking at designing a device that will not only allow them to practically and functionally take care of the houseplants, but how we can combine the act of taking care of plants with exercising, do the specific exercise to improve the condition of our...
I made my grandma wash dishes. She hated it. But, I mean, think about it. If you have arthritis in your hands, you know, and her first response was, I can't use them, you know. And you say, live with me, you're washing dishes. And lo and behold, when she was done, her hands were feeling better. The warm water, the motion, but when you say that, you know, I mean, I just got, and it's just I think, you know, I mean, as we move forward, and that's what I like about aging in place stuff, especially when you talk about home designs and all that stuff. These are things that were developed for an aging and disabled population to allow people to remain in their homes, but they're really just good design in general. You know, and when you mention arthritis and clean, I mean, the first thing I thought about is, you know, simple levers and stuff. You know, I mean, it's, you know, I got a new pair of not hedge clippers, but branch clippers. And remember the old ones that were the handles were about this long, and they're extendable now. And now you got much more leverage, and it's a lot easier to work. So, you know, I mean, and these are things that, again, it's just things that relate to independence and, you know, looking at a piece of technology, it's a little bit differently than we might have. And how can that little piece of technology, you know, the big screen TVs, for example, they weren't developed because people had vision issues. They were developed because we like to watch football on a 50-inch screen. You know,
ego issues.
Yeah. You know, it's kind of like the old BMW and everything else. Who's got the biggest car now? Who's got the biggest TV? But you know, they help with an aging population, and help people remain at home independent with some level of dignity.
Well, the issue too that talking about foreign countries is the cultural aspect and how we view aging, because we're so focused on staying young here in America, we don't even want to stop at 50 and say, what if I live to be 90? What's it going to look like?
Yeah.
How am I going to pay for it? Less than 2% of my clients have long-term care insurance.
Yep.
And the ones who do say, God, I thought this was so cost prohibitive in the 80s when I bought it, but I'm so glad I have it now. Well, we need to get that message out so that the people are more proactive than reactive, because when you're in crisis mode, you just look at 2 or 3 sites and you say, okay, that's the one.
Yeah.
And you may have been making the wrong decision, or antiquated technology, or not have all the information.
There's a lot of hope, assuming they make some changes to the Class Act. You may have followed the Class Act, and it's kind of a national, and it's not even long-term care insurance, because it doesn't operate the way long-term care insurance does. It doesn't give you the flexibility, but it gives you some funding to, assume you invest in it for X number of years, to purchase and to purchase services, and that service could be a wide variety of things that would sort of make us think about these types of things. And that's a challenge, because we don't want to think about getting older and getting injured. And you know, I mean, I just for the first time bought disability insurance. For me, I don't plan on getting disabled, and my wife said, you know, you're our only income. You better get something. You know, so the more rational thinking part of her made me buy long-term care. I mean, disability insurance.
When you turn 50, you get that AARP card in the mail, and it's right there.
You get it at about 45 now.
45. Oh, do you?
Yeah.
Okay. but then you know what is to, how do we get that same message out when you turn 60 or what have you, about just think, what if you lived another 40 years? Okay, now how's that going to look? Because they still think, I mean, I see seniors all the time that say, yeah, I live in this 3-story house, I'm going to live here all my life. And then you come back, and when you're providing services, they're relegated to the basement because it's got the rear entrance accessible to the driveway. And it's just, you don't know what you don't know, and how do we get that message out? That's the challenge.
So speaking to where academia is going, at least in my circles with the more technology side of things, one of the trends that I'm seeing is more of the self-management, addressing the self-management side. So getting away from just this response to a condition, I mean an acute injury or similar, but more into how do we enable older adults to take control of their chronic conditions, so relying on the doctor, saying that doctor's going to fix me. So I'm seeing insurance companies that are trying to figure out where to position themselves in the technology space, evaluating emerging technologies for weight control, for social communication, things that are fairly simple at this point, but also looking into the future of how can we determine over long term how well somebody's doing, so that more longitudinal understanding of the specific conditions.
Yeah, at the policy level as well, we're seeing that same movement. The guidance we're getting from the Administration on Aging and even CMS to a great extent is geared along those lines. Self-direction, but the other part is when there are acute conditions that happen, how do you and the phrase they're using is activate the patient. How do you activate the patient and get them actively involved in their health issues? Because right now, people aren't really actively involved in their health conditions. I get sick, I go to a doctor, they fix me, I go home, and then I wait until I get sick again. We're not actively managing our own health. And there's a fair amount of applied grants right now in aging to develop a delivery infrastructure that will activate the consumer. It's always an interesting way to think about it, but when you put it in the context of a healthcare setting and acute events, or even chronic events, chronic illnesses, people really, I mean, in my old psychology days, I don't remember the terminology, internal, external, what? Control, yeah, locus of control, yeah. A lot of people, when it comes to healthcare, I mean, you have the few people who really take an active and believe they can, influence their health. But most people, it's a diabetes issue, and I mean, I'm gonna wait until I get sick and then I'll go to the doctor. And I'm gonna say, I think most of us are the same way. I've been battling a cold now for 2 months. Since before, well, maybe not 2 months, but since before Halloween, I'm just finally getting better, and yeah, so. If it got bad enough, I'd go to a doctor and they'd give me some B12 or something, and I'd feel better. But I'm not activated yet. But how do you move that? How do you get towards that?
I have 2 things on that. One is, I know with the insurance companies, they started using health coaches. And I'm a coach, so I've gone to that from nursing to doing public health to doing marketing, because it doesn't work. And I think what you have to do is work at the individual level and find out what motivates them and get their buy-in and hold them accountable. And they've done it with the younger population. So I think with the older population, can we explore that and how it works with tech? Because like you said before, someone doesn't want to be monitored and get this call from a stranger, oh, your sugar is up. So if they have someone that they know that they're working with and is working with where they are, and I think we have to look at health professionals. We know where we want people to be, but if it's not what they want, it ain't going to fly. So I think that's an important thing to look at. And I forgot my second point. So.
One of the, we had a presentation by Pat Clark yesterday as part of National Family Caregiver Month, who was talking about a project that she was involved with that was over at the Emory School of Nursing, and one of the things that they were looking at was activating the caregiver partner. In using technology and feedback and to do that. The technology wasn't necessarily high tech, but it was basically 24-hour urine measurements of sodium and comparing that to a food diary. And you say you had 3 grams of sodium, your urine says that you have 6 grams of sodium. How do we begin to reconcile that? And this notion that I've been interested in how we can use technology to activate the partner or the caregiver, and in some ways that's part of the human interface that sometimes is going to work great.
I think that the second part of what I thought about coming, I don't know if you're familiar with computerized physician order entry that started, and one of the big issues were they sent all these alerts when something was wrong. Well, what happened was the physicians started ignoring them because there were so many. So So I think when you're using technology, how do you set the alerts? What's important? I'd look to the individual, what's important to them. And one of the beauties I've seen in coaching, which I've not seen in any of the other teaching and things I've done, is individuals can come up with their own solutions that I never even thought of. And once it's their solution, they will work and do it.
And that encompasses this consumer direction, the consumer oriented. I worked with a hospital system, and we did some research on consumer directed healthcare, and it was with the OT department. And we had two groups. One of them got the traditional occupational therapy rehab. You gotta get up and you gotta walk and you gotta do this, you gotta do this, you gotta do this. And the other group said, what's important to you? What do you want to get out of this? Do you want to walk down the driveway and check your mail? Is that what's important? Then we'll work toward that goal. And invariably, the groups that they were working toward a goal that was important to them, they improved better and they had better outcomes than a group that was going through traditional therapy. And on a bunch of different levels, not just on actually being able to get up and walk around again and do the things that were important, but on levels of depression, decreased levels of depression compared to the other group, higher outlook on life. Just all these different measures that we didn't even expect to see, when we did consumer-directed healthcare, and it was really interesting, but it's the hospital system went back to doing things the old way because it was too difficult to chart on. But the outcomes were great, and the OT that we were working with was also a faculty member, and she worked at the hospital. And she continues to try to incorporate and infuse some of that through it. No, that was all. No.
Well, one of the things I read in the summary, Claudia, was that you were going to speak a little bit about collaboration. And I'm really interested to know, because you started out by saying, you're new in Georgia and you're learning that there's sort of an old antiquated way of doing things and we're not open to technology. And so how can we use all of this wealth of knowledge and experience in here to help the state and to break through that and move forward? And what kinds of things can you do to help bring in our collaboration?
Yeah.
Exactly. I was just about to ask that question. How we can wrap up this conversation is like, okay, thank you for coming and sharing from it. What we can do.
Yeah. Well, there's a lot we need to do. One of the first things I did as soon as I got here, maybe shortly after I got here, my staff brought me to visit with Brian in the Aware Home, which was really incredible. And Georgia really has some really great resources when it comes to aging in general. And I just think I came from a state where I was essentially the state gerontologist when I was a faculty member. And then when I moved to the state, they lost the state gerontologist, and they're still trying to fill that position. So students, if you're graduating, I think they have a position open still. But just the resources with UGA and GSU and Georgia Tech and all the other schools that have an interest in that, it's really exciting for me anyway, from a professional level. But on the technology side, I have a personal interest in it, but I haven't really done research in technology and aging since I graduated. I don't know what the latest is. I know, my wife's a dietitian. I know the assistive devices for feeding and those kind of things. That's why you hear me talk about and sippy cups. They don't use that term. They created a new kind of cup for an adult that's not demeaning. At the time, this was all there was. But I have no idea what the latest and greatest is. I know the vendors who come to my office and try to sell me on stuff. It's like, well, you can't sell it to me. I don't buy it. Our contractors do. But the other part that we need help with is and how do we address this and present it as such that we reduce a lot of the barriers to it. There's a whole lot. We got at the state level 5 people, including myself, who's kind of taken us in this direction. There's no way we can do it by ourselves, and we're really dependent upon that. We've already started making some connections with the DD community and the independent living centers, because in a lot of places, the ILCs, independent living centers, really are leading the way on technology. Now, I've yet to make it I've met with the directors of the independent living centers, but I've not actually made it to one of their offices. I know you mentioned the roving display that was taken to the AAAs. That's something that we did in Louisiana when I was there. The state purchased from it was the LATAN, Louisiana Assistive Technology Access Network. I think the same. Yes. And we had them do it for us because again we recognize that we don't have we as a state don't have the expertise in the technology side because we've never done it. We've never systematically said we're going to go forward and we're going to start infusing technology in how we deliver services and how we advise clients who are participants in our programs.
And it's through the CILs have received funding and continue to receive funding from our grants.
Yeah.
So that's where we have really made an impact.
Yeah.
And so I'm thrilled to hear you're talking with them.
Oh yeah,
they're very much involved with our statewide reuse efforts, the STAR network, and some of the other things we're doing. They've got the Assistive Technology Resource Centers there. But I got to tell you, when I look at our data, we're mostly serving people who are in the employment age group because they're out there and looking for things, and to the extent to which we can, get more collaboration, going back to what you asked, it is crucial.
Yeah.
I just feel like there's so many people that we're not reaching.
There's a whole lot of people we're not reaching.
And I know that we've had requests for things like video magnifiers. That's a perfect example of something that some people who are older, they're losing their vision. They want to still be able to read. They're not sure they want to use talking books or anything like that. And yet if we had better lending libraries of just video magnifiers or simple solutions to that as opposed to some of the higher.
There's a great website, and if you've never been to it, I go to it probably weekly. It's called Instructables. Has anybody ever been to that website? And if you go to Toys R Us right now or any place else, you see these little microscopes that you hook up to your TV. They cost all of what, $40? At Toys R Us. Now, what does a video magnifier cost?
It depends.
There's quite a lot. Yeah, but the website Instructables and I love it because it's people like you and I who like tinkering around with anything, and they go and they rebuild something that's already exists into something that's useful, and I can easily see, does it take a different lens to make a microscope into a video magnifier if it's already got, you buy the package and you just take that one part, but I think the technology is again out there. Maybe we don't go about looking at the right pieces that's there. I want to talk a little bit, and how much time we have left. On the side of technology and aging, and students, you may start looking in the literature right now. But I think in the next 5 to 10 years, most of the technology stuff that we'll see, the cheap, inexpensive, but effective, will probably be coming from China. When I was on, I still am on a board of the National Association of Long-Term Care Administrator Boards. They're the folks who license long-term care administrators, nursing homes. We're in conversation with China right now, and they're building what can best be described as nursing home towns. Entire communities that they expect to serve between 5,000 and 10,000 adults who need nursing home level of care. Yeah. And they were talking to us. We did accredited programs and everything else in long-term care administration on providing training to the folks who are going to work in these areas. Now I can't even fathom how do you begin to create a nursing home that can serve 10,000 people. But I suspect you're going to have a whole lot of technology involved in that, both high and low tech systems. Now, as the last conversation we had, they were really in the very early stages of planning this. But it's China, the demography of China, what's happened with family planning and those kind of things, where you can have a huge number of people, who aren't going to have family caregivers. And one son generally, or a weighted one son. So it's something I've been monitoring right now, and just because we're working with them on academic programs and those kind of things. But think about, in the U.S., what would it take for us to design something that would serve 5,000 to 10,000 people in a community? And these are communities that are being built and designed for an aging population that needs nursing home care. Yeah.
How about we do it to keep them in their homes?
Huh?
Yeah,
That's our vision.
Well, The Chinese government hasn't asked us about that part. They're moving towards this, community, and
maybe because it's 5% of their population is
our entire population of the
right,
U.S. Yes,
know,
yeah. So, but anyway, it's just something that's happening globally right now. Everybody's trying to figure this aging thing out. We're all really new at it. Nobody's really lived this long before in history. So it's.
These are further ahead than we are, about 20 years, right?
Huh? Yeah. So.
One of the crises I'm seeing now is we have older couples who've been living in their homes and they have to move, but they can't sell their homes. And I had someone in my office yesterday who says, we may just have to lock the doors and move into assisted living. And so could one of the solutions be looking at these homes that are in foreclosure or can't be sold, buying them and making them homes for people?
I'm trying to figure out, and I still I haven't had much time to really look that deeply into it, but with the state recovery right now, I'm trying to figure out what the state does when because I know the last 3 years the homes haven't sold like they used to. But I don't know what happens to those homes that don't sell. I mean, when the state recovery comes into play.
Reverse mortgages are a solution.
Reverse mortgages, they are, but well.
It's hugely expensive.
Yeah, but reverse mortgages also have a stigma attached to them from quite a number of years ago when there was a lot of deceptive practices going on with reverse mortgages, and we're battling that again, like with a lot of the other things. I mean, we are still battling the stigma with traditional long-term care that was created in the 70s, with poor quality care, unregulated facilities, and people still remember that, and that's part of the cultural history of the U.S. of what nursing homes looked like in the 70s, that have people dead set against going into them. That's why you're seeing I got a whole little not a book but a little notebook of how terminology is changing in the U.S. just in the U.S. right now, because of the stigma attached to aging and an aging population. Elder hostile changed its name. Anybody know what it is?
What is the new name?
Exploritas. Exploritas, because elder hostile has elder in it, and it's not attracted to people in their 50s and 60s who don't consider themselves elders. AARP was one of the first. They changed their name going on probably 10, maybe a little bit more years ago. Used to be the American Association of Retired Persons. Now it's just AARP. It doesn't mean anything anymore. And now they target people in their 40s. The Association for Home and Services for the Aged is, and I don't know if they made a public announcement yet, but they just changed their name to Leading Age. Leading Age. So gotten away from the Home and Services for the Aged, AGED, to Leading Age. And the group that I was talked about, the National Association of Long-Term Care Administrative Boards, is actively considering changing its name. Nursing homes, they're rarely known as nursing homes anymore. Now they're known as skilled nursing facilities, emphasizing the nursing, the skilled part of it, or you've gotten away from nursing completely, and it's rehab, rehabilitation.
In the CCRCs that we're working with, they're all called healthcare centers.
Yeah, so there's a lot of changes that's happening, and if you start mine, I got a whole list of entities that have changed their name because of the aging of the baby boomers and how do we remain relevant. And that's the same thing with technology and how we address technology. We're gonna have to, develop something that's good now, and is useful, but on the design side of it, how do you design something that somebody in their 40s and 50s today will want in the next 10 to 15 years?